Hello friends, welcome to Medico Mello. Today we are going to discuss the topic mitral stenosis in its practical scenario. We have seen the theory part of the mitral stenosis. Now we can look into the practical side of this mitral stenosis. The patient is presented with breathlessness, cough and hemoptysis. The breathlessness is of gradually progressive and it is of exertional type. That is, it increases with exercise and it is of non-seasonal type. And what about the cough? The cough is a non-productive type which is not associated with fever. It is associated with paroxysmal nocturnal dyspnea, that is the PND, and there can be a history of rheumatic fever in the childhood affecting the big joints. What are the differential diagnoses? It is mainly divided into cardiac causes and respiratory causes. In cardiac causes, it is most favorable for a valvular heart disease, that even the stenotic type. In respiratory diseases, it can be a COPD, that is chronic obstructive pulmonary disease. It can be bronchial asthma and many others like pulmonary embolism, pneumothorax and pleural effusion. These are the differential diagnoses if such a patient presents to the OPD. What are the signs of this mitral stenosis? The first and foremost, the pathognomic feature is the mitral facies, that is the malar flesh. It is due to the cyanotic cheek with a telangiectasia. It is due to the vasodilatation, that is the stasis of the blood in the cheek. But it is not that much evident in Indians and more especially in Keralites. It is more seen in fair people. So next is the pulse. Pulse is of low volume type as it is a stenosis, that is there is reduced cardiac output. Next, regarding the apex beat, it is of tapping apex beat and the S1 can be palpable. So if there is a right ventricular hypertrophy, then features of this right ventricular hypertrophy can be seen. It is the left parasternal heave, epigastric pulsation and right hypochondrial tenderness. Next, if we go to the auscultation, there the typical murmur we are hearing, that is the mid-diastolic murmur. We have to describe the murmur with some other points too. That is, the murmur is a low-pitched, rough rumbling murmur. It is heard in the mitral area and there is no radiation of this murmur. And it is heard more with the bell of the stethoscope and it is more heard in the left lateral supine position and more evident at the peak of the aspiration. That is, left-sided lesions are more heard in the peak of the aspiration. Right-sided valvular lesions, the murmurs are heard at the peak of the inspiration. And why there is no radiation, we have to see. Carefully listen to this. The left atrium is seen just behind the left ventricle in its anatomical position. So as the blood is coming from the left atrium to the left ventricle via this mitral valve, it is flowing in the direction from the posterior to the anterior. So the murmur is not radiating as the flow is in the posterior anterior direction. So that's why this mid-diastolic murmur is not radiating. Then next auscultation finding is the loud S1. Why it is loud S1, that we will be discussing later. Next is loud P2. Why there is loud P2? It is seen only if there is pulmonary hypertension. Next is there is opening snap which is heard just after the S2, that is the second heart sound. And there the murmur, we can see pre-systolic accentuation. So in short, we have to describe the murmur as mid-diastolic murmur with pre-systolic accentuation and an opening snap. Next, we have to look into the symptoms. Symptoms due to reduced cardiac output, there can be fatigue and syncope. Due to left atrial failure, there can be dyspnea, orthopnea, PND, cough and hemoptysis. Why there is left atrial failure? Due to increased left atrial pressure and there occurs left atrial hypertrophy. Later on it becomes left atrial failure, and these features of dyspnea, orthopnea, PND, cough and hemoptysis are features of the pulmonary hypertension development. So here the hemoptysis can be due to bronchial vein rupture associated with the pulmonary edema, and this bronchial vein rupture is the most common cause of this hemoptysis. So there develops the pulmonary hypertension features, and this leads to the right ventricular failure, which is an after effect of this pulmonary hypertension. And we have to see what is this right ventricular failure features. It is following this right ventricular hypertrophy, and this right ventricular failure is seen as pedal edema. And some other signs of this right ventricular hypertrophy are increased JVP, epigastric pulsation and right hypochondrial tenderness. And regarding this pulmonary hypertension, if there is severe pulmonary hypertension, then the MS becomes silent. That is, due to much reduced cardiac output, there is temporary symptom-free period, and all the symptoms of MS are absent there, and that is the silent MS in severe pulmonary hypertension. So we have seen that only the right ventricle fails, the left ventricle is safe. Why? Only those structures which are seen before this affected valve are damaged, and that's why only the right ventricle is failing. And one more thing we have to keep in mind, that there is left atrial hypertrophy, and the recurrent laryngeal nerve is passing much closer to this left atrium, and while it is getting hypertrophied, recurrent laryngeal nerve is compressed, and that causes the hoarseness of voice, which is known as the Ortner syndrome. We have to look why it is a mid-diastolic murmur. The blood flows just after the opening of the mitral valve, that is from the left atrium to the left ventricle. That is, in the early diastolic phase, there is no blood flowing, that is in the isovolumetric relaxation. Here in this cardiac cycle, just after the ventricular systole, there is ventricular diastole, and the ventricular diastole has got an early ventricular diastole stage and a late ventricular diastole phase. This early ventricular diastole is known as this isovolumetric relaxation. Here both the mitral and the tricuspid valves are closed, and no blood is flowing into the ventricle via the mitral valve. So here in this early stage of this diastole, as there is no blood flowing via this mitral valve, there is no murmur in this early diastole stage. In the late ventricular diastole, the blood is flowing via the mitral valve, and due to this turbulence, we are hearing the murmur in this late diastolic phase only. This flow of the blood occurs just at the middle of this diastole. Hence, the murmur is heard only at the mid of the diastole, and hence it is called as the mid-diastolic murmur. Next is, what is this pre-systolic accentuation of the mid-diastolic murmur? That is, the last part of the ventricular diastole coincides with the atrial systole, that is the last rapid filling phase. Here, just before the ventricular systole, there occurs the atrial systole. In all these stages, there is ventricular dilatation, and this last part of the ventricular dilatation, there occurs the atrial systole. This atrial contraction is just before the ventricular contraction. So in this atrial contraction, more blood is flowing across the mitral valve, more noise of the murmur is heard out during this atrial systole. So here at the atrial systole, more amount of the blood flows across that stenotic valve. So hence there is increased murmur, which is just before the ventricular systole, and hence it is pre-systolic accentuation, that is pre-ventricular systolic accentuation. In this diagram, we can see that there is S1 heart sound, S2, and there occurs this next cycle S1. Here from the middle, we see this mid-diastolic murmur with an opening snap, and towards the end of this diastole, here there occurs the atrial systole and more amount of blood is flowing across the mitral valve, and there is accentuation of this murmur towards the end. Next, we have to see what is the opening snap. Opening snap is the bellowing down of this closed mitral valve cusps, which is at the onset of the ventricular diastole. That is, this mitral valve opens just now, but it has not yet opened. Just assume a situation where you are trying to open a very tightly closed door, a big door which is tightly jammed. So initially, while trying to push it open, we hear a loud sound, crack. So that sound is the opening snap. It is a sharp, high-pitched sound which indicates the mitral stenosis is organic. That is, if there is an OS opening snap, then it means that the lesion is at the mitral valve and it is of the organic type. In severe mitral regurgitation, there can be a situation known as the functional mitral stenosis, where there is no organic lesion to the mitral valve similar to the mitral stenosis. There occurs mid-diastolic murmur but without an opening snap. Next is, if there is opening snap, it means the valve cusps are pliable, which means if there is calcification, then there is reduced opening snap, or sometimes it may be absent. Then significant MS, that is, if there is opening snap, then it means that the mitral stenosis is much significant. And next is lesser the S2-OS gap, that is, lesser the duration between the second heart sound and opening snap, then it means that the mitral stenosis is more severe. Next, why there is S1 being louder? First of all, let me remind you, S1 is due to the closure of the mitral as well as tricuspid valves. Throughout the diastole, the valves are wide open. In spite of the stenosis, the valves are kept open throughout the diastole. Why means, as there is stenosis, only less amount of the blood is passing via the left atrium to the left ventricle through the mitral valve. So due to this, only less amount of the blood is flowing. So for a longer time, this pressure gradient is persisting throughout the diastole. Due to this persistent diastolic gradient, the valves are kept open for a much more time. So once this flow of the blood has come to an end, and once this left ventricle is trying to contract, these opened doors are shut immediately and rapidly, and this causes a loud S1. Just assume a door which is kept open for a much longer time, and you are suddenly closing the door, and that causes a loud sound. Then factors that affecting the intensity of this S1. We have seen the wide open cusps, that is in the mitral stenosis and tricuspid stenosis, causes the loud S1. And just opposite to that, closely approximated valves in mitral regurgitation and tricuspid regurgitation. It can be seen in myocardial infarction and myocarditis. That causes just opposite, that is the soft or muffled S1 heart sound. Then next is the short PR interval. If it is the shorter, then the more louder the S1 sound. Next is the pliability. That is, if there is calcification in the mitral valve, then lesser the pliability and softer or fainter this S1 heart sound. Next is the ventricular muscle mass. If there is left ventricular hypertrophy seen in systemic hypertension, then there is the booming of S1 heart sound. Next is tachycardia. In tachycardia, the PR interval is much shorter, and that causes the loud S1 heart sound. Next, very important thing, there is the media between the heart and the stethoscope. That is, in case of empyema thoracis, in case of pleural effusion, in case of pericardial effusion, the S1 heart sound is faint. as there is obstruction in between this heart and the stethoscope, the heart sound you are hearing is much fainter. Hence we can classify this loud S1 from the soft S1. The loud S1 we have seen in MS and TS, whereas the soft S1 is heard at the mitral regurgitation, TR, empyema and opacity. Loud S1 is seen in tachycardia due to short PR interval, and soft S1 is seen in bradycardia due to prolonged PR interval, and in hyperkinetic circulation seen in severe anemia, pyrexia, exercise and pregnancy. The heart sound S1 is louder, whereas in calcified valves this S1 is softer. This loud S1 is normal in children, and in case of right ventricular or left ventricular dysfunction, the S1 is softer. Regarding the severity of this mitral stenosis, we can assess with two criteria. First one, the gap between the second heart sound and the opening snap. It is inversely proportional to the severity of the mitral stenosis. That is, lesser the S2 or S gap, then more severe the mitral stenosis. Next, the second one is the length of the murmur. It is directly proportional to the severity of the murmur. That is, or longer the murmur, then more severe this mitral stenosis. Next, we have to look into the reason why the dyspnea occurs in the night in MS. Why? Because there is increased venous return at lying down posture during the night. So more amount of the blood reaches the heart, so the heart has to do more work. And next, the second one, the edema fluid moves from the extravascular compartment to the intravascular compartment, and that again increases the blood to the heart, making the heart more difficult to pump all its blood. Next, third one, the adrenergic drive, which is reduced during sleep. The fourth reason, the heart rate is increased during the REM stage of sleep. And lastly, the vital capacity of the lung decreases at supine position. That is, while standing, there is gravity helping the diaphragm to get down, whereas in supine position, this gravity is eliminated, so the vital capacity of the lung is decreased. And these are the reasons why the dyspnea is nocturnal in MS. Some of the X-ray findings of the MS. There is enlarged left atrium, and that can be seen in the chest X-ray. There is straightening of the left upper heart border. There is widened carina angle due to left atrial hypertrophy. This is the carina angle, that is the angle between the left as well as the right bronchus. Due to the left atrial hypertrophy, this left bronchi is up, so that causes the widened carina angle. Fourth, there is double atrial shadow. Next, there is increased transverse diameter of the heart due to right ventricular hypertrophy. See here, the transverse diameter of the heart is increased, and that is evident in the chest X-ray. Next is the Batwing Sign, which is a typical feature of the pulmonary edema. See, this is the Batwing Sign. It looks like a bat in your chest, and this is due to the pulmonary edema. Next is the curly B lines, which are interlobular septum, which are enlarged at the pulmonary edema. And lastly, we are able to see distended pulmonary veins, which are due to pulmonary hypertension. Next, we have to see the differential diagnosis of the mid-diastolic murmur. The mid-diastolic murmur can be heard at acute rheumatic valvulitis, that is the Carey-Coombs murmur. It is seen at rheumatic fever. The pathology is that there are nodules which are formed in the mitral valve. And next is the Austin-Flynn murmur, which is a mid-diastolic murmur and heard at severe AR. Actually, in AR, it is an early diastolic murmur, but in severe AR, there is the regurgitant jet of blood that's striking on the mitral valve, and that causes this mid-diastolic murmur called as Austin-Flynn murmur. Here we can easily remember this word Austin-Flynn. Here there is an A and that goes with the AR, another A. So Austin-Flynn murmur for severe AR. Next is the functional mid-diastolic murmur, that is due to some other lesions. Examples are ventricular septal defect, atrial septal defect, and patent ductus arteriosus, which are congenital heart diseases with left-right shunt. And it can be heard at severe mitral regurgitation also. Why? Because due to increased flow via the mitral valve, that is, as there is regurgitation of the blood from the left ventricle back to the left atrium, anyhow towards the end this more amount of the blood has to be pumped out from the left atrium to the left ventricle, and this amount of the blood towards the end anyhow has to pass through this mitral valve. So that causes the mid-diastolic murmur, and that is known as the functional MS seen in severe MR. And next is, it is heard in the left atrial myxoma, and mid-diastolic murmur, as it is heard in the MS, it is heard in the TS also, that is the tricuspid stenosis. And lastly, the ball valve thrombus, that is the thrombus which is seen in the left atrium. It floats in the left atrium, and during the diastole it blocks the mitral valve, and that causes the mid-diastolic murmur in the ball valve thrombus. And thus we come to an end of our clinical discussion on the mitral stenosis. Let me remind you, the greater things never come from comfort zones. The struggle you are facing today are for a better tomorrow. Much greater things are waiting you in the future. Thank you for watching this video. Please like, share and subscribe, and this is Medicomalu.